Services FPS, and founder and director and CEO of FACTS, that is Fraternity of Advanced Cardiovascular Techniques and Solutions. FPS is the largest CV professional group of India. Dr. Sreenivas is also a founding course director for Advanced Cardiovascular Solutions in India. And he is also carries a prominent experience of teaching, and he has worked as a professor of general medicine at Pratima Institute of Medical Science, Karimnagar. Dr. Sreenivas was the past president of Andhra Pradesh Cardiology Society of India and chairman of CSI National Intervention Council of India 2018 and 19. Dr. Sreenivas was the executive member of National CSI in 2007, 9, and 13 and 15, and also a national convener in cardiac imaging in 2010 and 12. With this, I like to request Dr. Sreenivas to proceed with his presentation and enlighten us with his knowledge and experience. Over to you, sir.
Yeah, thank you, Dr. Vinay, for your kind words of introduction. And before we go, can you see my slides now?
Yes, sir.
Okay. So before we go on to the presentation, I thank Sun Pharma and for making this possible today. There are a lot of webinars go on and webinars start. So I was just telling all of you that we should be also thanking all our doctors who have logged in patiently to listen to this webinar. The topic which we're supposed to discuss today is again beta blockers. Though they're very old drugs, but they have a lot of important role to play in the management of CVD. And how many ever lectures you listen to on the beta blockers, you always get to learn one or new points in it. And wherever you challenge these molecules in any spectrum of CVD, again they come positive. But only one thing we all need to know is that these are a broad group of drugs, and we need to see all the drugs whether the same or which some of them have some particular advantages. And of late, it has some of these beta blockers have gone into disrepute. Those aspects I'll be touching upon in the coming 15-20 minutes. And later on, my good friend Dr. Raghu will cover on more individual details about individual drugs with case examples. This slide brings best wishes from Apollo Group of Hospitals. I'm proud to present these FACTS professional service colleagues who work as hub and spoke model in multiple hospitals and cover up and with a single point of agenda, providing quality care to the patients, especially in these tough times of COVID. This sort of net had a cooperation and helping each other goes a long way. And a lot of challenges this COVID gives us, and it wants us to maintain social distancing, things like that. But this technology has made us possible to have such interactions with various type of webinar platforms. So it can't isolate us socially. We can only demand social distancing. That's what I keep telling. So coming to today's agenda, what I would do briefly is tell you the burden of coronary artery disease. Is always good to recapitulate how important is unfortunately how it is rising in our country, and what are the predictors of coronary artery disease, and briefly touch upon management, but stress more upon the role of beta blockers and what are its spectrum across the CV continuum, where those drugs are recommended, and whether all molecules of beta blockers are the same or any heterogeneity, and cover up this important landmark evidence of articles on beta blockers and CB's Copernicus Merit Heart Failure Scene. This reminds me how these continuous medical education programs and CMEs are very important. When we were students, I think beta blockers were contraindicated in heart failure, they used to say. And now they become the drugs of choice. So it's very important for us to understand how the knowledge evolves and how the data comes. And that's how we try to give what is best for the patients. And then molecule of today, obviously the makers of Prolomet XL and the metoprolol, the Sun initiated this. And what is its role, particularly stressing on metoprolol, and where do you use and what are the advantages of this, and address some of these issues, why this molecule is preferred because of beta-1 selectivity, and show you some subgroup analysis which stresses on that point, and summarize in the end with giving you some take-home messages. That's what I would intend to do it. If you see the burden of coronary artery disease in India, this is unfortunate. You see the world over diagram, wherever you point, there is coronary artery disease. But India and China, Russia, these fall in the top category where you have maximum number of coronary artery disease. That's how many coronary cardiac centers come, how many cardiologists are there, physicians are there. Still, all of us continue to be busy, unfortunately, because of the rising this epidemic of coronary artery disease. If you see the prevalence of coronary artery disease in US, it is high, 15.5 million deaths, and it leads to high morbidity and mortality. If you see the specialty in India, it affects very early. A decade earlier, the people suffer with coronary artery disease in our country compared to West. And because of sheer numbers of huge population in our country, if it is actually, you speak 62.5 million years of life are lost prematurely because of cerebrovascular disease and coronary artery disease. Compared to US, it is actually 60% more. So that's how all the pharma companies as well as device companies stress a lot on this management of coronary artery disease patients in a country. And it's already reached, it's no more we are a developing country. The infectious diseases are no more common cause of death. Cardiovascular diseases are the commonest cause of death, and 25% of mortality is on the country. Is all happens because of it. And out of that, again, more than 80% is what is because of coronary artery disease or strokes. And the global disease burden in compared to the entire population, we are stand slightly higher to the world. Then accelerated, how it is rising. Then early age of disease onset. This is what bothers me the most, and the high case fatality ratio because of diffuse nature of disease. But fortunately, we have very good drugs to control it, and we also know how the disease is spreading. If you try to see what are the early predictors of coronary artery disease, a lot is linked to sympathetic nervous system hyper overactivation. In this COVID times, also a lot of people get stressed up, anxious, and then leading to trouble of various forms. So maintaining our calmness and doing various types of measures which decrease our anxiety, stress levels go a long way, even in present epidemic. So to recapitulate back, sympathetic nervous system overactivity, acutely if when it activates, like in some sort of stress in family, now some sort of things like this, even in seen in corona pandemic, could lead to acute myocardial infarction, sudden arrhythmias like atrial fibrillation, ventricular arrhythmias, or Takotsubo type of cardiomyopathies. We did see such situations in some families, especially stressed up with some particular personal events, loss, and things like that. Chronically, if somebody has sympathetic nervous system activation, then it could lead to hypertension, coronary artery disease, and heart failure. This is what is also shown here. This leads to electrical instability and then sudden problems. And then chronic problems of this could lead to arterial stiffness, LVH, and sometimes plaque ruptures, arthrogenesis, and acute coronary syndromes. If you see one of the Indian studies to quote, I think of one of a few of our Hyderabad centers were also part of it. When they tried to analyze 1,514 patients of hypertension, how many had sympathetic overactivity? 62.42% of the population who were detected to have hypertension had sympathetic overactivity. That means, though people say that hypertension beta blockers are not the drugs of choice now, though they have pushed it down in the recommendations, but people who have this sympathetic overactivity again tend to benefit by usage of these molecules. What is this? How will you know that sympathetic overactivity? Like people will be restless, inappropriate sweating, tremors in hand. This is very young people, software professionals, a lot of people who are under stress. We get into a lot of these complaints along with hypertension. So if somebody has a fast heart rate, inappropriate sweating, tremors in the hands, and the restlessness, these all indicate the patient could have sympathetic overactivity, which could benefit the use of this molecule. Why are we so much bothered about this heart rate and sympathetic overactivity? Is basically, if you see the beautiful study in this showed what is the importance of heart rate, though it was done with heart failure. Basically, people, when they've divided them into more than 70 and less than 70, when the heart rate is more than 70, that's why we keep telling our fellows residents also, whenever heart rate is high, especially around 100 or more than that, you try to see what is some problem is there the patient. So we always need to see what is the cause for high heart rate. And patients who had more than 70 heart rate compared to less than 70 heart rate, they had a significantly higher cardiovascular risk, 1.34 times more. And similarly, the fatal and non-fatal MI occurrence was also more. And then if you see hospitalizations for heart failure also were significantly higher in this subgroup of patients who had heart rates of more than 70. So that's how the sympathetic nervous system overactivity in the form of high heart rate is indirectly leading to a lot of these problems. There are a lot of other trials which are listed here with huge number of patient populations, 6,743, and then here there are 2 lakh plus. Then a lot of other significantly large volumes of patients, meta-analysis, pooled data, all that shows that wherever the heart rate is high, then people are landed into incrementally higher mortalities, both cardiovascular and non-cardiovascular. And then probably if the heart rates were better controlled, then they had a risks becoming less. So some studies showed there increased tendency of 23%, some showed 10%, but everybody, all the studies showed that higher heart rate leads to higher problems. So that's how now we know that sympathetic nervous system activity, high levels lead to hypertension, also chronically stimulating lead to coronary artery disease. If you come to the management of coronary artery disease, apart from the pharmacological therapies and interventions which we do, which we cover, this sympathetic nervous system, adrenergic systems states are very well controlled with lifestyle adjustments. So if you see this sort of a dynamic process leads to sudden plaque ruptures and leading to ACS types of syndromes. So this lifestyle modification, doing yoga, meditation, walking, having healthy diet, and avoiding smoking, and then go a long way in preventing these acute problems in patients who already have hyperadrenergic type of situations. Pharmacological management, coming to it, basically we have various groups of drugs in angina, CAD, which we use. I won't go into details of all others, but all the things are mentioned here. But out of these drugs, beta blockers are only the drugs which have significantly have the capacity to control the heart rates. But it comes with some price, sometimes with decreasing contractility and sometimes decreasing atrioventricular conduction. But the advantage of this, the molecules, is reduces myocardial oxygen demand, reduces time to angina, and that's how people could walk more, exercise more, prolongs the diastolic period, and decreases the perfusion, improves the perfusion in ischemic area. That's how ischemia decreases. Those are the characteristic features of beta blockers. Some of these calcium channel blockers also could have vasodilatory properties. And nitrates, again, they have, but sometimes cause tachycardia. Ivabradine is the newer molecule, which if patients are not tolerating beta blocker or get heart rates are still high in spite of using beta blockers, probably this could use. Nicorandil is again different mechanism of action, ranolazine different mechanism of action. All these do not have the capacity to reduce heart rate so much. So that's how we have a single group of molecules which can control heart rate very much. So if you see how is this happening with beta blockers, as I said, reduces heart rate, but contractility also is reduced a little, and AV conduction reduces, but myocardial oxygen demand decreases, and time to onset of exercise, the angina also improves with usage of beta blockers. It prolongs the diastolic period, increases the perfusion ischemic areas. That's how the patients who have evidence of ischemia benefit enormously by usage of these molecules. That's how these drugs are recommended as first line of treatment in hypertension complicated with CAD, angina pectoris or prior MI, and heart failure and atrial fibrillation. Mind you, significant proportion of hypertension patients have these problems. And whenever such problems are associated with hypertension, again, you use these molecules. So newer hypertension guidelines, just isolated hypertension, though they have pushed this molecule down after the ACE inhibitors, ARBs, and calcium channel blockers, and maybe diuretics also. But when these hypertension patients have these associated features, again, we need to take the help of beta blockers. Why beta blockers became out of vogue and recommendations-wise went down is probably because single point of this reason. Most of the previous data studied was with atenolol and propranolol, which did not have the advantages of selective beta blockade like metoprolol and carvedilol. Now we see this more and more data on these newer molecules in the coming subsequent slides. This is again a beautiful slide which demonstrates the efficacy of beta blocker. I always keep telling these are the molecules. Apart from this, ACE inhibitors also have similar effects. Basically, you see any stage of development of disease, right from risk factor level in hypertension to development of atherosclerosis, myocardial ischemia, coronary thrombosis, MI, arrhythmias, then again after MI, LV dysfunctions happening, and CHF until death. Every stage of atherogenesis or a cardiovascular continuum of disease, beta blockers have proven to be useful. So that's why it's very important for us to know how to use these molecules correctly. So that in 2019, European Society guidelines rightfully said that in patient indications of beta blockers, you see all the subgroups here. Everywhere beta blocker is there. So don't think just because in the hypertension guidelines, beta blockers have gone down, but hypertension again with recent MI, beta blockers. Patients with hypertension and angina, again, beta blockers. Angina with where you need ischemic relief, beta blockers. Symptomatic heart failure, ischemic cardiomyopathy situations, LV dysfunction, again, beta blockers are to be used. This is as latest as 2019 European Society Cardiology guidelines. Then only problem what we need to understand with these beta blockers is all beta blockers are not the same. Some people have the habit of using traditionally very strong presence in physicians and some of the practitioners is atenolol. That atenolol is okay to decrease the heart rate and improve the control of pressure, but it doesn't have some of the advantages which these newer beta blockers have, like lipophilicity and prevention of sudden cardiac death and other things, which I'll be sharing in the subsequent slides. If you see the pharmacodynamic basis of these beta blockers, that's what selectivity again plays an important role. And then if a non-selective beta blocker, carvedilol, has some advantages in heart failure, but again, it is not very selective, only for beta 1 specific. If you see this is the strength of metoprolol or molecule of today. The beta 1 selectivity goes very strong, and it has indications in all the disease entities which are mentioned here, be it hypertension, angina, arrhythmias, MI, heart failure. This molecule has strong recommendations. That is because of the selective beta 1 selective action, and also it has the lipophilicity and it has advantages of sudden cardiac death prevention, which are not there with atenolol. If you see the evidences of these beta blockers which have come, be it be any type of newer type of beta blockers which we mentioned, Merit heart failure again used metoprolol here, risk reduction 39%. Copernicus used carvedilol here, mortality again decreased significantly. If you see bisoprolol in CBS2 trial, again significantly. All-cause mortality nebivolol, though it is decreased, is not as much decreased as with metoprolol and other carvedilol, but it also has some advantages, especially in elderly heart failure. So in a lot of these landmark trials of beta blocker, always they proven as winners. This again, like a cartoon, is a different repetition of the same and prevents the plaque ruptures, prevents abnormal remodeling, and prevents that's how the patient's going into end-stage heart failure. So it's very important to understand these molecules. Now let us see in which are the types of trials in which this metoprolol was used. Metoprolol in hypertension, MAFI trial was used compared to diuretics. Obviously, this is not the right comparison, I feel, because diuretics compared to that, metoprolol anyway will come as a superior thing and significantly decrease the silent MIs and non-fatal myocardial infarctions and compared to diuretics. And the metoprolol in stable angina, as I said again, wherever there is angina, heart rate needs to be controlled better. And there's no other drug like beta blocker which can control the heart rates very well and control angina. But only thing is we need to use the appropriate dosage of this molecule. Many of the times you start with 12.5 milligrams of metoprolol, be happy with it. Patients will not get the benefit of it. If you see this, even people have gone up to usage of 95 milligrams of metoprolol per day, and here 190 milligrams. Normally, the maximum dose we go up to is 100 milligrams twice daily. So 190 milligrams as compared to 96 milligrams. If you see the benefits of the maximum dose will be much, much more compared to those. Why it is so? Because the maximum dosing only can control the heart rates better. Our aim is to keep the heart rates around 55 to 60 in these patients of CAD, and that will be achieved only with the usage of proper dosing of this molecule. If you see in acute MI, again, COMET, CCS, and other trials were done in this small study. Metacard trial again showed before taking up these patients for PCI in acute MI situations also, it showed prevented the incidence of occurrence of LV dysfunction. That's what this trial shows. And Merit heart failure trial is again important trial in the heart failure, which is compared with metoprolol succinate, and a significant decrease, 34% reduction of all deaths happened in this with metoprolol. All-cause deaths and hospitalization also decreased. And they tried to analyze whether diabetes made a difference both in diabetics and non-diabetics. It significantly improved. I think it will be further covered by Raghu in subsequent talks. And if you see which subgroup of patients benefit with this usage of molecule, be it male, female, US, Indians, any functional class, EF less than 25, more than 25, any subgroup of patients you take it, always the study shown it favors the usage of metoprolol. So the benefit of usage may be slightly more and less, but most of the times it comes as a winner and benefiting. If you see sudden death prevention, which is the biggest strength of beta blockers, is decreased by 41%. Heart failure reduction, 49% reduction. And hospitalizations, again, significant decrease in these trials. So if you see, many people have the habit of using nebivolol and carvedilol and bisoprolol too. Then when this is not a direct comparison of each drug, but if you see the CBS trial, which was done with bisoprolol, and Merit heart failure trial with metoprolol, both are heart failure type of trials. Just as a simulation, you can't take it directly on the face of it, but CBs use bisoprolol, which caused 34% reduction of events, whereas the metoprolol in merit heart failure decreased by 42%. That means slightly better. Carvedilol in Copernicus 35%, metoprolol 39%. Nebivolol, as we said, is slightly less capacity of reduction of events compared to metoprolol. But I would always stress this is not wise to compare like this, but it gives you an idea that significantly probably more better effects would happen in metoprolol. But obviously, it depends upon the subgroup of patients in which you are taking this molecule to study. The more risk the baseline population has, the more benefits they could get with the usage of appropriate molecules. This is what is most important, I would say. We know now that beta blockers work in hypertension, heart failure, and many other problems, many other conditions. But what is the ideal dose of beta blocker which you need to use? That we generally titrate and see. We need to get appropriate heart rates of somewhere around 55 to 60, 65. Some people keep it not more than 70, because whenever the heart rates went up to 70, all the problems increased in the various trials which I've shown before. So we need to always keep the target heart rates around 60 or so, and the patient can tolerate it slightly less. But if it goes down to below 50, then they start getting symptoms like fatigue and things like that. So that's how we prefer heart rates from 55, 60 like that. So beta blockers, that's how is now appropriately used with appropriate target doses, then can become important drugs. So, but only thing is target doses we have to achieve. Then if you're not achieving by this molecule, probably sometimes we take help of ivabradine. If you see target doses of beta blockers in various trials itself, how many of them could achieve? In significantly in various trials, the target heart rates and target dosing could be achieved. Even in the trials, it is not up to 100%, but the 80 to 90% range. But in day-to-day practice, commonly, if you see, it will be much, much less. Only about 50 to 60% of patients are given the appropriate target dose. So that's how it is important for us to see to give these appropriate dose molecules. So how to give these molecules? You don't start away straight, especially in heart failure patients with very high doses. You start with smaller doses initially and gradually doubling of the dose as the patient tolerates it with once in every 2 weeks or so. Sometimes the patients could not tolerate these because of various other things, when the over-diuresis or things like that. We should also try to adjust the dose of other drugs so as to increase the efficacy and tolerance of beta blocker. This, I think, is a good algorithm, which I would take 2 minutes to explain. Is basically any patient's heart failure with LV ejection fraction less than 40. That is what we call as systolic dysfunction. The patients, if there are no contraindication, obviously shock and all that, we are not talking here. And then if their situation is like that, we stabilize them, then only think of using beta blockers later. But if nothing of that acute condition is there, then probably start with an initially smaller dose. If you are using metoprolol, the molecule of today, 12.5 milligrams gradually we start, and twice daily, and gradually increase the dose. Our target dose is achieving 200 milligrams per day. But before achieving this dose itself, if patient has achieved a target heart rate, what we want is 55 to 60 and appropriately controlled blood pressure, that is okay. But if patient has high heart rate, 100, still going on more than 70, don't hesitate to step up the dose. And many times people think that carvedilol is smaller dose, bisoprolol more smaller dose is better. You can't take it like that. The pharmacokinetic effects of bisoprolol 1.25 milligrams could be equal to say 25 milligrams. That is the pharmacological differences in the dosing patterns, not that this is more powerful, this is less powerful. Ideally, what we should see is what is the heart rate or pulse rate which the patient had. So that is how you need to titrate this molecule and gradually step up the dose of molecule. If the patient is tolerating without this worsening of heart failure, bradycardia, hypertension is good enough. Otherwise, sometimes if the patient is not tolerating, you have to see whether volume depletion is happening, or when you have to decrease any other calcium channel blocker or any other drug. Or sometimes you might switch one group of beta blocker to other, which we rarely do it, and patients could tolerate. The idea is to give the benefit of this molecule as much dosing as possible to these sicker patients, because that benefits the patients in the long run. This I already told. Does beta 1 selectivity matter? This is studied in these various drugs in the CB's trial, merit heart failure, Copernicus, and seniors, and these things. Though nebivolol showed slightly less of benefits, but all other three molecules showed good. If you're comfortable with any other molecule, use it, but provided you use it in appropriate dosing. Then there's a large number of trials which shown, the meta-analysis which show that all the trials showed that beta blockers come favorable And this meta-analysis did not show any particular advantage with any particular type of beta blocker. Mind you, all these are newer beta blockers, not the old ones like atenolol or propranolol. Then that's how now we know that I think to conclude, basically beta blockers now we know that have a good place in the management of coronary artery disease, heart failure, and also helps in prevention of acute coronary syndrome episodes. And matching the beta blocker properties with clinical condition can improve the outcomes, and probably you do the appropriate target doses. That's what is important in this, giving appropriate conditional help to these patients of CAD and heart failure. Thank you very much for patient hearing. I thank all the cardiologists who logged in. Why I wanting to show this is basically we made all these video on demand, all the lectures which are very much appreciated are all available in the website. All of you can go through in your free time and get the benefit out of these lectures. And we also started this platform called FIFA for training young medical graduates, because this corona pandemic, people are not able to attend classes and go to hospitals. And with professionals, we started teaching students. Thank you very much for your patient hearing. I
Thank you,
think
sir.
with this, I request Dr. Vinay to take over and introduce Dr. Raghu to, I'll stop sharing. We can have discussion after the second talk also, I think, no?
Yes, sir. So
Yeah,
thank you
yeah.
very much, sir, for an excellent presentation, and it was very enlightening to us. Moving ahead, I'd just like to introduce our next speaker. So the next prominent speaker from Hyderabad is Dr. Raghu. He's an intervention cardiologist and a vascular specialist interventionist from Aster Prime Hospital, Hyderabad. Dr. Raghu is having more than 15 years of experience in interventional cardiology in treating simple to complex cardiac condition. He is one of the pioneers in transradial procedures in India and has still till date performed about 30,000 diagnostic catheterization and 15,000 angioplasty procedures. Dr. Raghu has formed a novel initiative, Act Against Amputation in Diabetic Patients. Dr. Raghu is an executive member of Cardiology Society of India and a founder of Training Academy for Cardiovascular Interventions. He has been the recipient of numerous awards, prominent among them being Srimati Kirpalkar Memorial Gold Medal for the most compassionate resident in All India Institute of Medical Science in 1992. Dr. also received Sri Krishna Memorial Gold Medal for the best research work done by Cardiology Society of India in 1999. And he has achieved Best Young Intervention Cardiologist at Live Asia PCR 2007 and received the Best Intervention Case Award at 7th Asia Pacific Endovascular Meets for the year. With this, I'd like to request Dr. Raghu to continue with our next topic, that is Be Selective in Selective Population, case-based discussion on the role of beta blockers. Over to you, sir.
Thank you, Sun Pharma, for giving an opportunity to share our experience on in cardiology to various of our colleague physicians. I think people can see my screen. I think, yeah. Dr. Vinay, are you able to see the screen?
Yes, sir.
Okay. Good evening. Thank you, everyone, for attending this webinar. This evening, Dr. Sreenivas Kumar has given a fantastic foundation for the clinical scenarios in which beta blockers can be used. People consider that beta blockade are very old drugs and old-fashioned drugs. But at the same time, if you look at the diverse indications in which beta blockers are useful, is phenomenal. You look at hypertension, you look at heart failure, you look at angina, you look at thyrotoxicosis, you look at anxiety neurosis, you look at multiple cardiac as well as extracardiac where there is a sympathetic overdrive. Beta blockers remain a core concept in the treatment of these disorders. So I don't think anyone can write off the beta blockers or think that they're old-fashioned. The only thing, as Dr. Sreenivas has made very brilliantly, is how much to use, and what is the importance of reaching the target dose of the beta blocker. That is very important to get the maximal advantage. I don't think anybody makes a dish with a half salt. You add the desired amount of salt. So also you want to give beta blockade, given the right dose, given the right one. So that is what we are discussing this evening about extended release metoprolol, succinate, that is Prolomet XL. That is what we are discussing. So if you are thinking, metoprolol comes under two formulations. One is a tartrate, which is a short-acting one, and the other is a succinate, which is a long-acting one. So what we are now discussing is about an extended release metoprolol preparation. That is the drug which is shown to reduce the mortality in